Thank you very much. Good evening, everyone. Welcome to our second cardiology grand rounds. I'm Partho Sengupta, and as the Chief of Division of the Cardiovascular Disease at Rutgers Robert Wood Johnson Medical School and University Hospital within the Rutgers Barnabas Health, I once again welcome you all to the second grand round series. As you would know, that the first 2 months in the fall this year, we are dedicating on examining the future of cardiology. Last week, we focused on the digital transformation of cardiology. And I'm very pleased that many of you have returned back your comments and personally met me and told me that you have found the discussions invigorating. Continuing on the same agenda this week, we bring to you on the topic of how this digital transformation is going to impact the experience for the patients, the connected patient continuum. As again, we are the voice for the future that aims in improving heart health throughout the creation and dissemination of knowledge with an aim to create an environment that fosters collegiality, collaboration, respect, diversity of thoughts and action, and most importantly, innovation for transforming cardiovascular care and outcomes. And I'm really pleased today that for innovation to take place, we have to break some rules and some paradigms. This week, we have taken an exception in our presentations, from the CME office and with the courtesy of their willingness, we have been able to bring in a voice that breaks down the barriers of industry academia relationships. I'm thrilled to introduce to all of you Dr. Maulik Majmudar. Maulik is co-founder and chief medical officer currently of a company called as Biopharmus. Prior to joining Biopharmus, he had multiple roles in academic divisions. He was the Associate Director for Healthcare Transformation Lab at Mass General Hospital and an assistant professor at the Harvard Medical School, where he conducted several pioneering work in identification, validation, and implementation of digital health technologies to improve healthcare delivery, as well as patient and provider experience. Maulik was also founding member and chief clinical officer of Qantas, a venture-backed medical wearable startup that was developing some wrist-based devices that time. And most importantly, after a hiatus, he took a leave from academia and moved on to become a force in Amazon. He joined as the chief medical officer at Amazon. And subsequently, just before I was transiting and coming here from West Virginia University, I got a call from him one fine morning that he was coming back to Biopharmus. And this is a company that he had formed along with his own mentee. And that company was doing some great work in the Boston area and in other places. And we have worked, I've known Maulik at ACC, at the ACC Innovation section. We have really enjoyed working and talking about the future of cardiology. And I thought it'll be a great idea for us to have him present his viewpoint. And along with his viewpoints being presented on the connected patient care, that he's going to focus on, we also have for our discussion forum 2 stalwarts. We will bring back Sanjeev, who gave the grand rounds last week. So Sanjeev, as you all know, is a physician scientist in healthcare innovation and practice transformation at Scripps Clinic, and gave a very stimulating presentation last week, which is a wonderful segue to this presentation. And along with Sanjeev, we also have extremely important person who has joined us and given us her valuable time. Dr. Regina Drews. Dr. Regina Drews is the immediate past chair of the Healthcare Innovation Council and has been working with ACC in trying to fundamentally change of how innovation is practiced and is assimilated by the membership at the ACC. She's the chief of cardiology at St. John Episcopal Hospital and integrative cardiologist at St. Francis Hospital, medical director of integrative cardiology, founder and executive director of Holistic Heart Center of America, and CEO and co-founder of iVisit MD. And in my opinion, I do not know of anyone else who has been so entrepreneurial in her role in bringing together what we call as the digital transformation, actually embracing it. And I think as many of us work here along with our friends and community in New Jersey, I think she will be a perfect example of someone who has really innovated the clinical practice. So with these introductions, now it's my great privilege to bring back Malik. And Malik is going to go ahead and give his presentation. Malik?
Great. Partha, thank you so much for that kind introduction to all of us. And also thank you for the invitation. It's a really pleasure and an honor to be here, at least among friends, actually. So Sanjeev, Regina, Partha, and I have spent a lot of time at the ACC in the innovation section. So really great to be here. Let me go ahead and share my screen. As I pull it up, the way I was thinking I was covering this next 30 minutes or so was twofold. One, I did want to piggyback on Sanjeev's presentation last time and really talk about the impetus behind our transition in this term is what I title as digitally enabled care model. The time is now. And the second half of the talk, I will focus on how lessons learned in doing innovation work in academic health systems. That was my work at Mass General, the Innovation Lab, which I hope Partha and others will be hopefully valuable, just thinking about how we structure our innovation lab and how we actually implemented some of those projects and what kind of results we were able to achieve. So with that, thank you, Navina, for sharing clearly. I can see your screen now. So that's great. If you hit Control L, if it's a desktop, it's a PC, it'll go to full screen view. There you go. Perfect. All right, next slide. So every time I start this talk, it's always helpful to start with the pain point, right? What is the problem we're trying to solve? And I think this slide is really interesting to me. Folks may have seen something similar, which is if you look at life expectancy at birth as a measure of value of healthcare, and you compare that against the x-axis, how much money do we spend as a country in terms of healthcare spending per capita? What's very clear without any statistical tools is how much the US is an outlier. And if you look at the size of the bubbles here, really represent, well, is it because we're spending just so much money on more and more office visits? And if you look at number of doctor visits per year, it's clear that we don't. In fact, Japan and the Czech Republic and other countries have a lot more clinical interactions. And despite all that, they achieve great life expectancy at a very low cost, and we don't. And our neighbor, Mexico, which has a similar amount of clinical interactions per year, can still achieve reasonable life expectancy at a much, much, much lower cost than us. So I think the problem we're trying to solve for is really value. How do you deliver the highest quality care with the best clinical outcomes in a cost-effective manner without doing too much, without doing too much. Next slide. So really, as I think about medical practice today, I think it's clear that we've been practicing medicine in a very reactionary manner that's relatively episodic, right? A single visit per year to the physician or 3 visits a year. It's very provider-centric. We still go to the brick and mortar practices, the clinics or the hospital to get care. For the most part, people still get paid based on how much you do, so volume, but not value. And it's relatively inaccessible by our patients. As you know, access to care in New Jersey and everywhere else in the country is a massive problem. So ideally, we want to move towards the right. I want to read all the words here again, but ideally, we want to do everything opposite, right? We want to be proactive and continuous and really deliver accessible and high quality care to patients. And the question is, how do we do this? When I first started this journey a few years ago, my first thought was, next slide, I have this nostalgia notion of the the house call, right? The family doctor, no matter how much it's cold outside, or is it rainy or snowy, somebody's not feeling well, you call your house doctor, they would come home to you with the doctor's bag, they would, examine you, give you some treatment, and you'll feel better the next day. I think it's interesting to think about the trajectory of house calls in the US over the last 50 to 70 years. And it's really diminished, quite frankly, right? To a little less than 1%, but it's slowly making a comeback. It's making a comeback partly because of the convenience and accessibility in relationships of house calls and doctors visits in the home. But in my slide that I just shared, if you go to the next slide, it's still, next slide. It still doesn't achieve the full futuristic value, right? Sure, it's going to be more patient-centric. Sure, it may be more accessible, but still not going to be continuous, proactive, and high value. So if we go to the next slide, the question I always ask myself is, why now? Why now is the right time for this kind of transformation to take place? And why now is an interesting question. I think there's a fourth element of the why now. I have three points I want to make here. Go to the next slide. But the fourth one clearly is the pandemic. But the first and foremost, going back a few years ago, was really the healthcare reform. Obamacare is popularly known. It really triggered or jump-started this whole movement, partly because of payment reform. Right? It was the first time there was a policy that said that we're going to transition to paying more for value of care that you deliver than just the volume of care. And this move to value-based care away from fee-for-service really jump-started this whole movement. And as part of that, one of the foremost things they did was start the Hospital Readmission Reduction Program, HRRP, which actually gave readmission penalties to hospitals that had above average admissions, 30-day readmissions. And they really incentivized hospitals to say, we have to control, we have to take ownership of the quality of care that we deliver so patients don't come back to the hospital within the first 30 days. And if you can imagine, this is hard to imagine now, but if you imagine, there was no incentive for health systems before this to actually, care about if there were too many readmissions to the hospital, because each time the patient got readmitted, it was actually financially rewarding for the health system, because it was they could charge for it. So these sort of policies really started this movement. And last but not least was quality incentives. There's also money and budget allocated to actually achieving higher patient satisfaction scores and specific quality measures around cardiovascular risk factors or other risk factors. Next slide. The other big component of this movement is specifically on the technology side, this exponential technology curve. And people may be familiar with Moore's law, this idea that there's a doubling of computing power. And with each doubling of computing power, there's actually 50% reduction in the cost of these transistors, semiconductors. It really goes to show you that we have this miniaturization of technology. If you look at the computing power for smartphone today, is comparable or better than actually the amount of computing power required to send something to the moon in the 1960s, right? Or 50s. So this idea that you can do a lot more in your palms or your fingertips today than ever before is really also contributing significantly to this transition to the world of digital or digitally enabled care. And the third piece, if you go to the next slide, is really around consumer demand. This part, I think, is unique to this generation than ever before, that patients and people are a lot more engaged in their care, and they want to take a lot more ownership and understanding of their care. And part is because of the internet revolution, of course. But the other half of this really has to do with medical bills and medical debt. Medical debt is the #1 cause of bankruptcy in the US today. And if you think about health plans, health insurance, the growth in high deductible health plans has been exponential over the last 7 to 10 years, with $12,000, $14,000, $20,000 out of pocket pay on an annual basis. So customers and consumers are really wanting to take more ownership of the kind of quality of care they're delivered or where they seek that care. So this combination of policy, technology, and consumer demand has really, I think, transformed the adoption and need for digital technologies. Last but not least, which is not on the slide, is clearly the pandemic. I think, we try to launch telemedicine for telecardiology, 6 years ago today at Mass General. And I recall adoption was so slow. It was not zero, but it was very slow. And with the pandemic, of course, as everybody knows, there's been a 1,000-fold increase in the use of virtual visits and telemedicine, but it's coming back down rapidly. So again, this impetus of like, what is it that really is the driving the necessity for transitioning to digitally enabled care is interesting. If you go to the next slide, so this digital revolution really started years ago with the quantified self movement, and Sanjeev covered this pretty well. If you go to the next slide, but the term digital health, I think, has become this catch-all phrase. So I just want to be mindful that when people use the word digital health, 7-10 years ago, it was fine because only a few things we were doing within this umbrella. But at this point in time, I think it's exploded to include everything from health IT to classic electronic medical records, which I would not call digital health at this point, to all the way from the brand new big data, sensors, wearables, the stuff Sanjeev talked about, AI, machine learning, gamification. There's all these different components. Virtual reality is a big rising sort of interesting tool. So a lot of these things all fall under digital health. But I think if you want to get to the specifics, it's important to tease apart different aspects of technology, enabling technologies. And I think it's time to get more nuanced because there is so much in this bucket of digital health. Go to the next slide. What is interesting is there is this emerging field of combination of sensors and devices with unique capabilities that are miniaturized enough that can be used in the home environment or in your personal hand or pocket even. And this combination of what are called form factor. Is it a handheld device? Is it a wearable device? Is it an on-body or in-body device? The combination of these two have really given rise to this whole world of biosensing wearables. And the reason it's interesting is that from a research and development perspective, it gives us the ability to capture signals in a way that's never been possible before. And number two, with the data sciences, it provides the ability to interpret signals in a way that was never possible before. The thing that's missing is how do you generate the evidence to show the effectiveness of these technology and tools to drive clinical care models that really is what we care about, to drive outcomes. At the end of the day, that's what patients care about, is they feel better and they live longer. And for health systems is, can you deliver that kind of care in a cost-effective way using these enabling technologies? But I think this is a very growing field, and I think it's going to continue to expand and grow over the next decade or so. Next slide. But if you look at the wearables landscape, what's been disappointing is that vast majority of the investments and effort has all been in the left side of the screen here, which is all around what's called consumer type parameters like movement or step count or heart rate. And that's more like fitness heart rate, not arrhythmias, or sleep. And that's not really sleep apnea detection, it's more sleep quality, right? So everything's really been focused on consumer metrics. And unfortunately, very little of it has been focused on true clinical metrics that you and I care about a lot about, that improves the lives of our patients. But to me, that's great, because that's an opportunity. It's an opportunity for Sanjeev, Regina, Partha, and I to say, well, let's focus on the clinical opportunities here. How can we take these consumer tools or devices and actually apply them to the clinical populations? Because they do have value, they may have value in certain clinical applications, and can we study them and generate the evidence required to prove that they can improve the care delivery for our patients. So I think, to me, I would look at these and actually think about the opportunity to create for someone at Rutgers or elsewhere to actually study these things and apply them to their patient populations, that it is not saturated by any means. There's plenty of opportunity. Next slide. This is an interesting figure from a paper I think Eric Topol published that Sanjeev may recognize. We try to talk about different parameters of the body in different organ systems that can be measured through digital tools, or can already be measured, or are ripe for new innovation or invention. And it really maps the entire body. And so if I had to have this classic, check engine light for the body, like a car does, what could that look like? What would I measure? And it really gives you almost like a library compendium of things you would want to measure. Of course, half of these things are not possible today, but it gives you a roadmap to what, if you were to partner with your engineering colleagues across the aisle, what would you want to work on potentially? So very interesting way of mapping out the human body and the kind of physiological signals that one would want to monitor. Next slide. But I think the key thing for me is, if people may have seen this kind of diagram before, this is the very famous Gartner hype cycle curve. So most technologies go through this curve at some point or other, which is you start with a technology trigger, then you have all these peak or inflated expectations. This technology is going to do everything. I mean, classic example, AI machine learning is going to solve all the problems in the world, right? Data science will. In fact, folks who've followed this field before, there's a very famous saying called the winter of 76, or the winter in the 70s, which is that AI was very popular in the 50s and 60s. And there was this one dark period in the 70s that nobody had any confidence in machine learning or AI actually solving any problems because it just wasn't working well. And now there's been a resurgence of interest in machine learning and data science. So there's always this inflected expectations. And you get this trough of disillusionment when you realize, oh my God, it won't solve a lot of problems. Watson's not going to solve all the clinical problems in cancer detection and diagnoses, right? We've all heard these stories. But eventually, there's maturity in the field, and you get to this plateau of productivity. Every year I do this slide deck, I change my star where it is. And I do feel like with the pandemic especially, there's been rapid and accelerated adoption of digital technologies. And I think we're in this uphill slope of enlightenment where people are recognizing the right areas of clinical medicine where technology can play a role, and importantly, play a meaningful role. And eventually we'll identify this in the next 5 to 10 years, a level of productivity where we're going to be symbiotic in the way we practice medicine, where we use technology and it won't be burdensome or cumbersome to use it, but actually be quite assistive and augment the clinicians in their care plans. Next slide. One of the biggest gaps I've noticed, and I alluded to this a little bit earlier, which is that as you look at the world of digital health, the first 5 to 7 years of it, vast majority of solutions were always focused towards patients or people with low medical complexity, consumers, or low social complexity, which is what I say the worried well, or some call the healthy and the wealthy, right? They're really not targeted to the patients in New Brunswick, New Jersey, right? The complex chronic disease patients with high medical complexity and high social complexity, social determinants of health. And that's, again, where I see the opportunity is where things are now transitioning from the bottom left to the top right. And I think as we do more of this transition, I think it'll become very clear the value technology can drive in the practice of medicine, but also the care of patients with really complex conditions. We can deliver better outcomes at low cost. Next slide. And the reason this matters to me, the reason this matters is the statistic that's always eye-opening when I read it, which is 5% of patients account for 50% of all healthcare costs. And it's astounding, isn't it? And if you go one step lower, it's I think 10 to 20% of patients account for 80% of all healthcare costs. So healthcare costs are very concentrated. And I think the reverse of this is the bottom 50% only account for less than 3% of all healthcare costs. So when I was at Amazon, and this is the truth, when I was at Amazon, if you talk about Apple or any of these companies, the thing that always gets me as a clinician is, I want to solve problems for that 5% or the 10, 20%, not the bottom 50% that really obviously may have meaning for the patient or the person, but at the end of the day has very little impact on the healthcare system. And I think this is where I think the North Star for me has always been, how do you try to build solutions? And Partho has been doing this, and Sanjeev has been doing this, which is how to build solutions for the people that really it matters. So next slide. So with this, let me transition this talk to the second half, which is, okay, all this is great, but how do you get to healthcare transformation if you're a health system, right? How do you actually transform care? So next slide. And people talk about innovation, right? Like this is all these terminology. Oh, it's a very buzzword. In fact, they're chief innovation officers everywhere. Somebody once told me when I took my role at Mass General, I was like, oh, great, you're going to do nothing. Because once you get the fancy title, that means really you're going to be ineffective, because all these titles are great. But the question really is, do you have the backing, support of both your clinical staff as well as the leadership to actually implement and deploy innovative solutions? Or is it more just lipstick on a pig? And you talk about innovation, but can you actually deliver? So next slide. So when we were at Mass General, one of the things we noticed that cardiology is super interesting here, right? We've had some great successes in inventions and innovative technologies, all the way from new stent PCIs, stent technologies, obviously artificial hearts, ventricular assist devices, even percutaneous valve surgeries. There's so many interesting innovations in cardiology compared to any other specialty, in my opinion. But if you go to practice of medicine, next slide, it's like pulling hair, right? Care delivery innovations are very, very difficult to implement, deploy, and have success at compared to technology inventions. So I think this idea that, implementation, execution is usually, people say 99% of the problem. Ideas are usually 1%, is absolutely true in my mind, having practiced and trying to do this in Mass General. So next slide. So what are some of the key barriers to why technologies don't get adopted or new ideas don't get adopted and deployed in the healthcare setting? I think there's a few classic ones that hopefully will resonate with some of you in the audience who've tried to do this. Is usually because of just how busy everybody is, clinician, the engagement level is actually quite low. And I think this series part that you've stood up around future of cardiology and even expand the future of medicine is really a great way to spark some excitement and awareness and education around what is possible. But that engagement level is only one piece of the puzzle. The rest of it is all around collaboration. So innovating in silos is something that was very common, at least at Harvard and Mass General, which is that there's so many interesting people doing interesting work with grants. They were all operating in silos, and there was very little collaboration happening. And that to me is a lost opportunity. But I feel like in other systems, that is not as big of a barrier that at least I observed at Mass General. There's of course competing priorities. I see Frank or others on the call here. A health system executive has so many things to consider. There's so many competing priorities, even for the staff, right? Nurses and physicians on the ground. There's always a new pilot, a new project, a new initiative, a QI initiative. How do you actually protect them from the barrage of new initiatives and new things? You do have to think about competing priorities. It's always the issue of misaligned financial incentives, right? I think one of the bigger challenges we noticed at MGH was we were transitioning to an ACO, but the cardiology clinics were still fee for service. So here you had the system level ACO who wanted to reduce the cost of care, but then we were judged on our views. Well, how does that work, right? So if you don't align incentives, how can you get engagement from your frontline staff? So really thinking hard about the objective and the end outcome you want to achieve, and making sure everybody's incentivized to walk the same path. And of course, last but not least, fear of failure. There's a lot of comfort leadership sometimes get from just the status quo. And Partho's the exact opposite, right? He's a true trailblazer. So I think you guys are super lucky, obviously, have Partho at the helm here. But there is this real concern that you get too comfortable in the status quo and you don't take enough risks. And part of entrepreneurship and is all about risk taking. And of course, calculated risk taking. You have patients' lives at hand here. So you cannot just take risks without understanding the consequences. But in terms of trying new things, challenging status quo, adopting new care models, you have to be open to a little bit of risk taking. So I think these are my lessons learned about common reasons new technology or new ideas don't always get steam or get adopted in the healthcare environment. Next slide. So this very briefly in the healthcare transformation, I'll give you a couple of slides on how we try to attack this. Next slide. So we had this mission statement that the goal for the HTL, the healthcare transformation lab, was to improve the experience and value of healthcare through collaborative innovation. And we said that right up front, we want to collaborate. We weren't here to another innovation lab, support in a corner who's going to do their own things. We just want to collaborate with everybody doing great work already. And then where we can add value, would bring in new ideas. So if you go to the next slide, the way we did this, there was four prongs to this concept. One was engage. We had a ton of meetings and meet and greets with so many different people in the hospital to really understand what they're working on, what we think we want to achieve as part of the healthcare transformation lab, and how do we engage them in a dialogue, a meaningful dialogue to work together. The next part was connecting the dots. Just by having these meetings, we were able to connect groups of clinicians and researchers and innovators across the health system that never talked to each other before. We must have had hundreds of meetings over the 6 years I was there, and it's connecting the dots. And that network effect is powerful. Finally, we did support a bunch of things, right? We supported grants, we supported projects, we supported deployment implementation projects. So we'll talk about that a little bit. So that was our contribution to the ecosystem. And then of course, catalyze. How do we get young, residents, fellows, junior faculty to just give them that spark and some support to take their idea and just run with it, right? So they don't feel like they don't have the support they needed to at least go to the next step. How do you get them to just that one step forward to see if this idea is a real one, or then to fine tune, refine it to sort of get momentum? So that's how we sort of, as our framework. Next slide. The three pillars, again, the focus areas for us at the time, which is probably not worth talking about in detail here, was really collaborative innovation, which you talked about, this network effect, technology-enabled care models. And I spoke a lot more about that today. I had this is 6 years ago. I had a strong belief that technology will really allow us to develop new care models that fundamentally change the way we interact with patients, where we interact with them, and how we interact with them. So we support a number of projects around that. And finally, to Sanjeev's grand rounds last week, validation studies. You have to fundamentally study these things and not be biased and not take it for granted that some solution is just going to work. Like, you have to study them in a rigorous scientific manner and publish to disseminate publicly what the findings were so others can adopt it. So those are the key components. Next slide. And here's the value proposition. This is maybe interesting for you is, we realized that we couldn't do everything. We didn't have enough budget to do everything. So what we said is we're going to help with the initial part, ideation discovery. So a lot of, catalytic grants, and I'll talk about two specific here, Etherdome Challenge and Co-Create programs to get the ideas and the juices going. Then we helped a lot with implementation and evaluation at the tail end. But we partner with other parts of the health system or private vendors to just design and build. Like, we knew our strength was not going to be in software development or machine learning. That's just not who we were. So we try to position ourselves as where our core capabilities were, and then partner with industry as needed. Our MIT, for us, across the street was MIT. So we partnered with the engineering school there to do a lot of this development building. So that's a great way. You think about your ecosystem of medical schools, undergrad universities, and hospital systems. How can you create this entire programs to collaborate across systems and entities to build an innovation program? Next slide. Actually, just skip this slide. This is just more leadership structure. So one of the first things we did, which I think was fascinating, was we launched an open innovation competition. So folks who haven't heard of this, there's a very popular professor at MIT and then Harvard who popularizes my idea of open innovation, that great ideas can come from anyone. And it's not just bottled up in like the, chiefs of cardiology. It's like a part of his brain. It can come from anywhere. So we had this competition, next slide, called Etherdome Challenge. And Etherdome is famous because that's the first time ether was used in the US, was a Mass General. So that's a famous thing called the Etherdome. The Etherdome Challenge was the idea to engage everybody at the hospital. So we had literally CNAs, medical assistants, administrators, so executive assistants, nurses, physicians, surgeons, chiefs of surgery. Everybody participated in this open innovation contest. We had over 235, it says here, the first year, submissions, and we graded and voted on all of these and eventually awarded 6 grants. But the idea was not the grants. Like, people are like, oh, what's the idea that won? Well, who cares? The idea was to engage people and get them excited about this concept of open innovation collaboration. The number of people that met each other to form teams and submit these grants and go through the judging process was so energizing for the health system. We did this for 4 years in a row. We actually eventually got funded by the health system to do this. And we were originally philanthropically funded. But this idea of an open innovation contest allows people to have the creativity and engagement, I think, that requires some kind of energy in the system. Next slide. Then we combined that with the actual program called Co-Create. And this was an entrepreneurship program where it was an accelerator. What we said was take these great ideas, have some hackathons and competitions, and then combine them with the sort of the brains of MIT, the engineers of MIT, with the clinicians of in Boston. And can we actually create a program to pass the ball to the next step, if it's a soccer game, right? Take it one step forward. Is this an idea with some legs in it? Can we support them to get some early feedback from clinicians on the ground? Can we do one small pilot? If you do all this, you can co-create and actually deliver something to the world. Let me wrap up with 2 more slides here. I know it's 5:40. Next slide. Concluding thoughts. Yep, go ahead. Next slide. So the future of innovation in my mind is three words, really. Is co-creation, convergence of technologies. So all this, the intersection of medicine, technology, data science, some kind of convergence of different disciplines have to come together to true innovations. They're transformative and not just incremental. And finally, collaboration. I think I strongly believe in this model. Is a model that I've always believed in, even at Bioformis now, as we partner with other entities. And if you go to the next slide, you can skip the next couple of slides and just go to the skip. Yep, one more. There you go. So these are the key requirements, right? This is pretty much the exact reverse of what I talked about barriers to innovation. Is it alignment of incentives, clear value proposition, risk tolerance, some long-term vision. These are all fundamentally important. It may seem like trivial now, but I think if you realize, if you go to the next slide, people may recognize these things. They don't exist today, right? In terms of like, there are no bookstores have gone virtual. You know, the films are all digital now, and nobody uses a VHS tape anymore. But if you look at the companies behind them, if you go to the next slide, the last slide, the companies have gone bankrupt because they missed a very important thing in their evolution, right? They missed the digital transformation. They completely were comfortable with the status quo. They thought they had a massive edge on what they were doing. They were leaders in their field, and they thought this new trend of digital transformation was not going to be sustainable, and they didn't want to switch or pivot or evolve with it. So I think if you think about health systems today, cardiology or medicine, I think it's important to recognize the trends externally and think about how they apply to our local practice of medicine. But I do believe the trend of digital transformation is real and here to persist. It will persist. And I think it's huge opportunities for us to be part of that story. Let me pause there. Thank you very much for your time, and hopefully this was informative.
Thank you very much, Maulik. And so we will have our panel back with Sanjeev and Regina joining back. And we will have some question and answer. So let me tell you, Maulik, what we are trying to do in New Brunswick. So I came here and we thought about the term innovation, and innovation is very aspirational, but we decided to create what will be a place, which will be called as an innovation hub, where free minds and free spirits can exist and design with whatever technology, have industry, academia, collaboration. Now, let me tell you, we are very unique here. We have multiple practices that have coalesced together, or they're independent, whichever way, but they do coexist, and there's a lot of collaboration that we have. Can you tell me how we could innovate in this environment, or at least I know that in Mass Brigham environment, there's a lot of private and academia, and all this boundaries have ceased. I mean, everything is some kind of merging together. What is the model of modern cardiology innovation?
Yeah, I think that's a great question. I'm curious what other people will say, but I think I have two thoughts there. One is you have to understand deeply what the pain points are of the folks you're trying to solve the problem for. So if it's clinical cardiologists, what is it that they're struggling with, whether it be on their patient care side or personal workflow side? What is it that they really want to solve for? Because then they'll be naturally engaged because you're actually helping to solve their problems. That's one. The second is you have to make it easy. A lot of these things in innovation programs require too much effort, right? Whether it be writing grants or doing the pilot, it requires a lot of effort. So how do you make it easy? And the third is also collaborative. So you can actually, you have to be open to say, I'm going to contribute to this part of it, and then somebody else in the team can do the rest of it. If you feel like it has to be 100% ownership, like a classic academic investigator from start to finish, it becomes very difficult for somebody who's practicing medicine 80, 90, 100% of the times to actually contribute. So you have to say it's a team effort, and I can come and go in and out. I want to be engaged and involved. I can't be responsible for everything. So how do you make it easy? How do you collaborate? And how do you really understand their pain points? Are the three ways I think you can achieve success is just addressing those things.
So I think you made some very interesting point, and I'm dying to ask this question to Regina, and I'll come to you, Sanjeev, also, because Regina is a perfect example of innovation that she's continuing to do in her own private setup, in her own academic setup. She's in ACC. How do you get it all done, and how do you innovate? And can you give us some example of? I see a lot of things that you're doing. Give us some examples of what you've done that has been really successful in your environment.
So Partha, first of all, thank you for having me, and I appreciate a very warm and kind introduction. I'm very much motivated by you, Sanjeev and Maulik, who are trailblazers, and I'm just trying to follow along. But to tell you kind of more in terms of the way that a person who is, let's say, is a clinical person or someone in a more traditional role can actually approach innovation is The most critical part of it is not to try to boil the ocean or solve the problem of the entire world. You have to find the problems and think of the solutions that could truly benefit people who are what I call are at arm's length, right? And so that arm's length component, that local component, brings you in touch with potential patients, customers, colleagues, administrators, who all are in that orbit. And by figuring out who are the people in that orbit, you can actually create a novel solution that goes through adoption. In my personal experience, bringing my practice in integrative cardiology to a very traditional healthcare system that is very much focused on fee-for-service as well as value-based contracts, that was a challenging part. So creating a framework that shows them where the value proposition was and trying to address the barriers to implementation and working with the individuals in a step-by-step fashion was something that took 2 years to accomplish. But once it launched, it became very successful. And it brings together not just a new practice model, but the digital health tools, as well as more of a branding and marketing approach to medicine, which is fairly new. And I think it sets the stage for additional innovation, for scaling beyond just, a single physician or a single department. So rule number 1, don't boil the ocean. Rule number 2, go and find the people who you work with every single day and figure out what their pain points are. And rule number 3, see if you can create a solution that resonates with those people and alleviates their pain points.
So Regina, give me a few more examples of digital tools that you use currently. It could start from how patients are scheduling with you because I see very innovative ways you do things. So can you tell us, because
Sure.
those have been some issues.
So, maybe some of your docs need to close their ears, but I'm the only, I think, physician in a health system who maintains my own private website, because it uses chatbots and patient quizzes that are automatically scored to allow our patients to start investigating their symptoms and understand how integrative cardiology or lifestyle programs may or may not be of benefit to them. I routinely use remote patient monitoring, which is direct to consumer, including Cardia Pro and all sorts of Bluetooth-enabled blood pressure cuffs. I use what Malik says, the wearables for the healthy and the wealthy, which are the consumer available wearables, such as an Oura Ring, as well as prescription available biosensors, such as continuous glucose monitor. And I integrate all of this, unfortunately right now, still piecemeal, into my continuum of care. So every one of my patients, in a way, gets supplied with this digital health toolkit, depending on the specifics, that allows them to address various facets of stable cardiology practice, typical cardiology workflow, as well as expand in that lifestyle integrative opportunity. I use telemedicine for approximately 30% of my patients. It allows them to self-schedule as well as for us to schedule on the back end. And the chatbot on our website is connected to content relationship management software and a platform that actually educates patients in between the visits. So this is sort of the final view of what the practice is like. It still, of course, needs a lot of work, but I do believe that for cardiologists, especially now, positioning their practices to be more patient-friendly, more accessible, and certainly leveraging the digital health tools that are readily available is a must. It's no longer, something that, is nice to have. It's something that they need to have.
And you have been championing this not only at the regional level at your center, but then you take this information and then you take it to the ACC level and you lead the section, and that's incredible. So I really like the idea of even people in the community who can have successful and fulfilling careers as innovators, both locally in their practices, but then also influencing the nation and national policies. So that's amazing. Thank you, Regina. Now, Sanjay, Sanjeev, I have this important question to you. Is now there's so many tools are coming. Let's say we come together, like Malik says, we identify the problem and we look for the solution and we identify digital solutions. Can you embed a digital study or a trial that can run without coordinators running around recruiting patients? And could you do it out into the communities, in homes, and recruit patients and create this clinical study, let's say, where you can farm out the whole study from the innovation hub out into the communities? Give me give me an idea of how people could participate in such a study.
Oh, absolutely right. And a pleasure to be with everyone today. I also continue to learn from Malik and Regina and Partho, and so so anything is possible, right? This virtual design, right? We see patients over telehealth across the country now, if we so desired, right? So as we look at that, Partho, how virtual can we be? Key questions we have to ask: what's our objective, right, for any specific program, right? And really to iron that out very well. This is where small, rapid, maybe iterative pilots help internal teams learn. Well, some pie in the sky ideas are great. It invariably changes then, right, to what you can actually deliver in your community, in your center. I learned this from Malik, right? Fungible and translational skill sets, right? That if our digital innovator, and as we've spoken about, there's a lot of facets here, right? The entrepreneurship, business development, clinical cardiology, got to know that very well, pain points. But then there's informatics, there's trial design, right? There is analyzing data. So there have to be these nodes of expertise, either in the inside or through collaborations, right? And as centers ask questions of how virtual can we be, completely paper-based clinical trials, enroll patients across the state, it's certainly possible. But we have to take one step back to that and ask, well, what skill sets are needed on this team in order to answer those questions? And what are those bioinformatics and translational approaches? Who understands this language of virtual? And now start building upon that. Put that team together. I've learned a lot also from Margina as well. Work with IT and IS, really understand your language at your institution, right? As you start asking these questions on how can I test a certain design? How can you integrate a different tool? And then finally, what outcome are you looking for in this program? Really vet these out. And as in doing that, one can then push virtual designs really to anywhere you need to, but it will be important first and foremost to your community and the patients that you serve.
So, but it is, in your opinion, possible to completely conduct a clinical study or a clinical trial virtually and using devices and without, I mean, that could be a really wonderful way to engage. And I think Malik is trying to say answer. And I think, Malik, you can try to add your comments, and I have another question for you.
Yeah, no, I just want to add one thing to what Sanjeev said. I think it's really interesting. One of the things we struggled with a lot when we launched the HTL was, did we want to be an enabler or did we want to be an innovator? And we couldn't do both. And we ended up deciding that we want to be enabler of innovation to have more impact and scale. So your question part, the one interesting way to address that is to say, if you, from an innovation hub perspective, had a common set of tools that you brought together, and folks across the community can use those tools for decentralized trials and siteless trials with e-consents and all these sort of things, then you could see how you could have 10, 20, 100 studies happening. As opposed to if you were doing it as an innovator, you would have 1 or 2 studies happening. So that idea of scale is very interesting. And those common tools is what I think you can really support. And that's where you can bring in industry and partners and say, hey, what are the newest tools to do virtual trials that can help my clinical cardiologists and residents and fellows really come up with their own study designs and learn and iterate. Anyways.
In that, Malik, just continuing, there's some proof here over the past year, right? Like the coronavirus vaccine trials were all done nationwide, completely virtual, from organizations that had never done decentralized trials before, right? And so there is very valuable lessons there on how do you execute, right? And so the answer, Partho, is yes, it is possible, right? But and to Malik's point, right, it's putting those toolkits in place, right, to ensure the foundation of the organization along execution are solid, right? And it iterates, right? And I'm sure Malik, Regina, you see it too. It's not a fixed mold.
That's right.
Right? Each program will change what you do next. So that's probably the most exciting thing of this.
Great. And Malik, I also wanted to ask a specific question. I know that this is targeted towards the home hospital at home concept. So I wanted you to tell us about the kind of studies that you're doing in light of these and whether you're using the virtual model. Would you like to enlighten us about what's happening in Boston and Mass General and elsewhere, which is going to be triggering innovation everywhere?
Yeah, no, great questions. I think there are, you're going to deep into this, but in terms of the digitally enabled care models, Partha alluded to, hospital at home for acute care. So the three components as we think about digital care, which is acute care is models where you can do acute hospital level care in the home environment. And what are the devices, technologies, and clinical support teams needed to actually do that in a safe way? Then there's the outpatient chronic disease management stuff, which is how do you actually deliver high quality guideline-based care, also leveraging technology. There are a lot of interesting studies happening nationally around pharmacist-led models or health navigator, community health worker-led models. So these are task shifting, using different role groups to do the things that specialists used to do. But the other aspect of what we're seeing a lot now is how can technology drive standardization, automation, and effectiveness, operational efficiency of those care models. So I think we're going to see an interesting hybrid over time of either different role groups doing it manually and or building on top of that, once you know the role groups can do it, automating that to technology. And those two, I think, is a whole world of clinical trial design that's not even started yet. I think it's super interesting. Brigham just submit an abstract accepted for our AHA coming up next month on 10,000 person trial for hypertension and dyslipidemia management, all done through health navigators. And they had way better outcomes than the clinical primary care or cardiology practices. And I think what you're seeing technology companies do, and it's not biopharma, like any company outside of us even, is to take those models now and say, can we now automate them? Because it's hard to hire 15 pharmacists, but you've proven the model already, not just automate it, standardize it. So anyways, I think that's opportunities there.
So and most important, now let me ask you more a question that everybody asks. Let's say if you were to become a person that the way you guys are describing, like an innovator who does all this digital studies and versus the typical cardiology, which has been procedural driven. Mm-hmm. Okay, who's going to be better off in the future? And how do we coexist? Because there's a tension, right? And is that tension true tension? Or we can probably do the both. And maybe I'll have this question answered from Regina, because Regina, do you think that cardiologists will continue to have satisfying careers and job satisfaction and the kind of salaries that we get if we were to transform ourselves into the way Malik and Sanjeev are describing? Because the money right now is RVU driven in many places and procedures drive it. Where are we going from here?
So, Partha, a phenomenal question. And I'm sure you're not the only person asking, because probably a lot of docs that you work with and all of us are asking exact same question. But I think what's important here is to understand that first you have to do what you're passionate about, right? You can't color yourself a different color if you hate it. You have to go literally where your heart is. And I think labeling people is another of those siloing schemas that we're so used to. We're used to this very traditional training process. First you go to college, then medical school, then internship and residency, and then maybe somehow you differentiate into a certain career track, and maybe one of those career tracks will be innovation. But I personally think that for innovation to become a part of our daily lives, it has to be adopted to a degree, by every single physician who wishes to remain in practice, whether they're doing something procedural or something a little bit more cognitive. Because at the end of the day, innovation is invention plus adoption. I wish I was smart enough to coin this phrase. It wasn't coined by me. It actually comes from Professor Zanis from Stanford, who runs a Stanford course on design thinking. And so being able to innovate means to invent and find a way to adapt. And I think this is where cardiologists need to position themselves when they choose their career paths, especially for fellows who are still in training. What is the career path that will allow them not to bring these inventions forth and to adapt? Inventions are not necessarily technology. It could be new practice model. It could be a way that patients perceive and interact with a physician or a department. Patients, for example, are always complaining about the phone tree or the fact that they cannot interact with a medical practice or a hospital as easily as they can, for example, with their bank or an e-commerce shopping site. So there is a lot of opportunities, and I think hopefully we can move from competition to collaboration and find this synergistic curve that, you know, brings cardiology to greater heights.
Wow, Regina, with those notes, I think there cannot be a better closing, because you just summarized it, and it's truly inspirational the way you did it. So I think the take-home points for all of us is to really examine this very closely and have this inward look of what we really enjoy doing and how we can innovate to take us from what we like to do to the next level, and not to worry about what it will take and who's going to get reimbursed what, because ultimately our lives are a single time opportunities, and in the way we can decide to exist and practice and collaborate and make this a better place for all of us. Thank you very much, everyone. The time is up, and I think we look forward to this continuing series. It's been really memorable, and it's given me also, as a chief of cardiology, to look into and examine the other ways we can bring all of these tools together. But I think the future will clearly unfold, and it will be very exciting. Thank you very much.
Thanks, Partho. Thanks, everybody.
Thank you, Partho. Bye-bye.
Bye.
Bye, guys.